Okay, well, Roman has drawn a nice diagram here of the structures. So, Roman, why don't you take us through this and how you use this intraoperatively?
Yeah, thank you, Charlie. Can you hear me?
Yes.
Yeah, okay, perfect. Sure. So I'm not Picasso, I apologize, but I did my best to do this nice drawing. I think the first thing when you use fluoroscopy is to have a perfect superposition of the condyles. That's one major thing you need. The second thing, which is to me the most important, is the posterior cortex of the femur. And once you have this, you can really draw all these different points here. I'll go through them one by one. So you have this parallel line to the posterior cortex, as I said. For the MPFL insertion, which is here, you need to draw a perpendicular line to this first line here, which goes to the posterior part of the Blumensaat line here, and to the posterior, the edge of the condyle here. So you have this, and just at the intersection of these three lines, you have the MPFL insertion on the femur. Then, if you go further, you have just above the Blumensaat line here, you have the insertion of the posterior oblique ligament, the POL, and here the superficial MCL. Then, if we go on the lateral intercondylar wall, which I have here, which is basically a triangle, as you see here, you have in continuation of the posterior cortical line, you have the intercondylar, the lateral intercondylar ridge, and here we draw the anteromedial bundle and here the posterolateral bundle. Now, if you go on the tibial side, you see here the anteroposterior diameter at about 30%, starting from the anterior point, you have the anteromedial bundle, and at 50%, you have the posterolateral bundle. Now, if we go to the posteromedial, to the medial wall, intercondylar wall, you have for the PCL attachments on the femur, you have here the anterolateral one just on the top, and the posteromedial one just below. And in between, you have the anterior meniscofemoral ligament, the Humphrey. So these are the points we want to show you. Then we go to the lateral side as well. The lateral side, which I personally don't use for fluoroscopy guidance during surgery, but it's nice to see where we are. And now I give the word again to Charlie.
Okay, so those are the landmarks we use and the drawings. And what I'm going to do is take you, and I'm going to show you the ACL. I do use fluoroscopy on every ACL. I've been doing it since 2006. And I do think it helps you as a surgeon. So can we go to the inside view? Oh, sorry. So do we have an inside view now? Do you guys have an inside view?
Yes, looks perfect.
This knee had a lot of osteoarthritis, big notch osteophyte. So we had to do a notchplasty to find the ACL. So this is the view from the lateral portal. So this is your classic lateral portal view. And the ACL is somewhere down here. The ridge is somewhere down here. But you get a much better view, and I think this is really important, if you switch to the medial portal, and you can see the ACL very clearly. Here's the ACL footprint right here. You see that? The ridge is right here. Can you see that? There's the ridge, and you can see the outline of the footprint. The other landmark, which is quite helpful, is the proximal cartilage border, which is right here. And that marks the deep part of the footprint.
Charlie?
So, yes?
Can you outline the AMB and PLB on that for us?
Sure. I'm going to actually do that with the microfracture awl, Rob, and we'll take some fluoroscopic images. If we get this in. Okay. So, for me, this is the footprint. And let's just take a fluoroscopic image. This is where I think the ridge is. So can we see the floor? And as Roman was saying, notice if you follow the posterior cortex and that sort of arch down, you can see that that's where the ridge starts.
Can you show us the fluoroscopic views?
There we go. Oh, sorry. Do you have that fluoroscopic
Yes, we can see it now.
Okay, so you see the nice continuity from the posterior cortex. So now I'm going to go to what I think is the center of the AM. So there's the arthroscopic view. And I would say about there. Fluoroscopic image now, please. Okay, is that the fluoro?
Yes.
Okay, all right, okay. So that's where the AM, and you can see this specimen has a large posterior condylar osteophyte. So there's your AM, center of the AM. The center of the PL, I would say, is about here. So now let's take the next fluoroscopic image. Okay, there. And then the center of the footprint would be somewhere in between here. Okay? And if there's time, Rob, I prepared a couple slides to show how I use a grid system to evaluate this. So
Yeah.
Roman, why don't you come in and show us the PCL attachment site, okay?
Yeah, so now the scope is on the lateral side, and we look at the medial wall, as you see here.
Can we turn up the volume a little bit for Roman?
Sure.
Yeah, so now we have a look at the medial wall, and you see that this patient has huge osteophyte here, so there's no problem to find the cartilage border. We took the PCL off, of course, and you see here that's the PCL attachment site, this huge thing here, and here would then be on the superior part in the notch. That's where the anterolateral would insert. Can you make a fluoro?
Fluoro, please.
Yeah. So it's a couple of millimeters here away from the cartilage zone, approximately down here. And the posteromedial one would be around here somewhere. Fluoro? Okay, so that's it. And usually, a nice thing, as many patients have this meniscofemoral ligament, which you can nicely find if you put the knee in the figure of 4 position, that would normally be here. Then it's just in the middle of these two parts. So again, fluoro here. Yeah, so that's the middle of it. Do you agree with these positionings?
We can see those well. Good,
Okay.
thank you.
Good.
Okay. So now we're going to go to the medial side, and Roman, let's take us through the MPFL, because that's what most of you guys are using this for. So I've made an incision here, and Roman, I've dissected out the adductor tendon, which you guys, it's difficult for you to see, but why don't you show us with the microfracture awl the positioning for the MPFL?
Okay, so can you do fluoro, please? So as I told you before, the points which we need, or the lines which we need, again fluoro, please, is the posterior cortex line here. Then we need to do another fluoro, please. The posterior part of the Blumensaat line, which would be around here, and the posterior part again fluoro. The posterior part of the condyle, and which is of course here difficult to find because of the osteophytes. And then it's just in the above these intersections that you would put the MPFL insertion on the femur. Fluoro. So you see that's where I would put it more or less. Do you agree, Charlie?
I might go a little
bit
bit
more posterior?
more posterior.
Yeah, right. Yeah. So yeah, again fluoro. So here again. That's
Yeah,
somewhere
about there. Is
yeah.
that you guys agree with that position?
I think that looks good. Any questions from the audience on this?
Okay. So now superficial MCL.
We have one question here.
Do we have the question?
Yeah, the question is if you put a K-wire in and you're looking for isometry, how often is it off when you have that point that you've chosen right there?
It's usually pretty consistent. I mean, that's the axis of rotation and the center of the MPFL. So you may have to move it a millimeter or two, but usually not much.
So that's something you can do very easily during
yeah.
surgery. You fix
Okay.
it on the patella first, and then you check it afterwards.
And you can show also the patella position, Rome. Yep. So we can take another fluoroscopic image. So there's the patella.
So usually it's on the upper third of the patella, fluoro again. Yeah, so that's where I would put the my upper tunnel, and the other 1 centimeter more distal from this point.
Okay.
Okay.
Okay. Now superficial MCL. You can show that.
Okay. So just do another fluoro. As I showed on the image before, on my nice painting, it would be around here, fluoro, just above the Blumensaat line. Just leave it. Yeah, so leave it around. I would probably put it around here, and so that's in the prolongation of the posterior cortical line, and it's just above the Blumensaat line on this, in this edge, around this edge.
Okay. All right. And then the distal part, if we come here, fluoro. Sorry, it's a little bit, if I flex the knee. Fluoro. There is the...
Yeah, we can't see it. Can you move the video down on the tibia?
I'll just move. Okay. Do you have a fluoroscope? Do you see the fluoroscopic image?
Yeah, we can see it now.
Okay.
Thank you.
So that's about 6 centimeters below. Okay. So those are the, I guess, the key structures on the medial side. I've also dissected out the lateral side, and I can show you the fibula attachment of the LCL. So this is, I actually have the ligament dissected out, and there is the attachment site. Sorry. Right there, okay? And then on the femur, similarly, I've dissected out the ligament, and I think it's here. X-ray? Okay. Any questions on that?
Can you show us where the popliteus is, Charlie?
I did not do that dissection, but I'm going to stick a probe back here. Another shot? Okay. I would think it would be about there.
How about on the femur?
On the femur, that I can show you. On the femur, I think it's right there. X-ray? Sorry. I have to find the condyle. Here's the condyle. It's probably X-ray? Right there.
Yep.
You agree?
Yeah, I think it's important that it's real close to the edge of the condyle there for the popliteus.
Okay. So that's kind of what we wanted to show here, Rob. If we have a few minutes, I wanted to show some data we have on the tunnel positions and how this at least has changed my approach to ACL. The slides are loaded up, so any questions here?
Any questions from the audience?
Okay.
Charlie, why don't you come out and start your presentation then?
Okay. So.
Yes, a question. Can't hear you.
Is this working? Okay. While we're waiting for Dr. Brown, I want to just comment. There's a question about isometry and the difference between anatomic reconstructions and isometric reconstructions. I just hope if we could discuss that quickly, that particularly with MPFL, you're not looking for the isometric point. You're looking for the anatomic point because the MPFL is not isometric in its path.
The question is about isometry versus anatomic, and the issue is that if you go for isometry, you're not creating an anatomic reconstruction. So you really have to look at putting things back anatomically so that it functions in the correct position, because for any of the structures we're talking about, isometry really doesn't put it back in the center of the attachment point. So there's no ligament that we're looking at, ACL, PCL, or any of the collaterals that really function in isometry in the true anatomic sense. So we're mainly looking at anatomic reconstructions so we can start early motion and get back to normal function rather than an isometric position, which wouldn't be as anatomic. Charlie.
Which one to go forward? Sorry. The green button? Sorry. No? Okay. So this is a study we just did at the ACL study group, and we asked surgeons, where do you want to be in the footprint? And we had them mark this on an X-ray, and you can sort of see this is the scattering of points. So sorry, can I go back? So this is where they want it to be. And you can see most people are in this sort of AM central position, but what you want is not always what you get. And this is where they actually ended up when we charted the tunnels fluoroscopically. So that's where I think the fluoro will help you. And we've now tested 200 surgeons, and this is the group we call the anatomic estimators. So there's the center, there's the footprint, And those are the anatomic estimators. You can see they're all over the place. These are the fluoro people. And you can see, except for 2 surgeons, they pretty much get it right. And then this is for the 200 surgeons we've tested. These are the estimators. If I go back again. Sorry. So there's the estimators, again, all over the place. And if you look at the fluoro group, pretty consistent. And this is from Norway, from Lars, your country. I've been working with Thomas Harlem in Bergen. He came and he spent a week with us, and we taught him the fluoroscopy, and I went there and we worked with him. And so this is the post-op data for 50 ACLs of an experienced surgeon. He's been in practice 15 years, and this was his last 50 ACLs before he started using fluoroscopy. On post-op day 2, they get CTs on all patients in his hospital, so they know exactly where the tunnels are. So you can see the tunnel spread there. So that's before fluoroscopy, and this is after fluoroscopy. Dramatic difference. So I would make the case that fluoroscopy can help us all as surgeons improve. And so I use it on pretty much every case. It takes at most 5 minutes to the case, and I think it can help you become a better surgeon. Particularly if you're training doctors and residents and fellows, I think this is a very useful tool to use to help improve the consistency of the tunnel placement. So that's basically what I wanted to say, and any questions?
Give the lights on, please. Can you use the microphone?
Does your flexion angle affect your identification of the spot at all?
No, we use this, what's called Bernard-Hurdle grid, and that's independent of the flexion angle. So we draw this grid, as you see, based on Blumensatz's line, a tangent to the posterior condyle and the proximal condyle. And so the data is slave to this grid, so it doesn't matter which flexion angle. Practically, in the operating room, I do it at 90 degrees, because that's the arthroscopic position that you're operating at. So 90 degrees is, but you could do it at any flexion angle.
And drilling your tunnel, does that change? That's your pinpoint.
Yeah.
So if your flexion, your angle of drilling affects what your ultimate tunnel comes out to be.
Yes, and that depends on your starting position. If you're drilling through a medial portal, if you start medially, you will be drilled perpendicular to the wall. You will create a circular aperture. If you drill more oblique, you drill an ellipse. So you have to take that into consideration. And it depends on the type of graft. If you're using a soft tissue graft, I want an elliptical tunnel, so I cover more of the footprint, so I drill more elliptically based. And I'll correct the fluoro and I'll adjust the fluoroscopic image to take that into consideration. So with the fluoro, you can kind of dial in what you want. So whatever position you want, you can check it, verify it, and then drill the tunnel. How often am I off? On the tibia, 20% of the time. Usually too anterior on the tibia. And I change it. It takes about 2 minutes to change it on the tibia. Any other?
Chris?
Yeah, I'll just make a quick comment that would be unpopular, but I'll preface it by saying I think it's absolutely critical that we understand the anatomy for these ligaments. We can't get too complacent, though. You know, as you said, isometric placement is not anatomic placement of these ligaments, but anatomic placement is also not anatomic placement, because what we're putting into these footprints is nothing like what was originally in the footprints. And so, particularly with the ACL, PCL is going to be a tough nut to shoot, but with the ACL, you know, the capital T may fall somewhere between what is an anatomic footprint and what is a reasonable isometric position for what we're going to be putting in that footprint. I'd be curious to get your thoughts on that.
Charlie?
Well, I think those are valid points, but at the end of the day, you have to choose a point. You got to choose some place on the wall to place the tunnel. And you can have different philosophy. You can go in the center. If you go in the center, you're going to have higher in situ forces. You're going to have a more horizontal graft. You may have a higher re-rupture rate. There's not hard data on that. You can move more towards the AM position. It's more isometric, smaller length changes, lower in situ force, but
not as good rotational control. So I think at the end of the day, each surgeon, you've got to figure out what's your philosophy, where you want to be, and you have to make a choice. And not every knee gets the same, and I adjust these sometimes. If I have a real big pivot, I may give them a little bit more PL. If I have a smaller pivot, I may move the tunnel in the AM bundle position between the center, and so you can basically a la carte surgery if you know where the tunnel is. And this gives you a reliable way of knowing your tunnel placements. So you pick the position, and I have one I like, but you have to decide where you want to be. Thomas is doing post-op studies, so in 2 years he's going to be able to correlate the final position with the clinical outcome. So in 2 years, I think he'll be able to tell us which tunnel positions gave the best clinical result. So that's the project we're working. That's the ultimate goal, is which one gives you the best outcome. So hopefully in 2 years we'll have some data on that.
Okay, thank you to all the faculty this morning. It was a great